Hello, everyone. We are pleased to welcome you to our second Maryland Rural Opioid Technical Assistance Project, Maryland ROTA, webinar in 2021. Maryland ROTA is part of a Substance Abuse and Mental Health Services Administration, SAMHSA, initiative. It is based at the University of Maryland and conducted in partnership with local and state organizations. Our PI is Dr. Jinhee Kim. My name is Erin Artigiani, ROTA co-director. Barbara Kerr, our digital media manager, and I will be the facilitators for this webinar. Maryland ROTA aims to strengthen the capacity of rural communities in Maryland by helping our communities identify, understand, and respond to the evolving drug crisis. Our multidisciplinary approach includes delivering evidence-based training and providing access to current information and local resources through the ROTA website, network, and webinars such as this. We encourage you to join our growing ROTA network to learn about best practices, access educational opportunities, ask questions of peers and experts, and share your local experiences. More information about Maryland ROTA and a link for joining our network are available at www.marylandrota.org. This webinar highlights lessons learned in planning and implementing substance use disorder programs in rural communities on the United States-Mexico border. Today, we are excited to be joined by two colleagues from the University of Texas at El Paso. We know that Texas has been having a lot of bad weather recently, and we're fortunate that our colleagues are in a part of Texas where their power seems to be working, so hopefully it will hold out for us this afternoon. Our first presenter will be Dr. Thenral Mangadu, Director of the Minority AIDS Research Center. She will be followed by Dr. Emre Umucu, Director of the Veteran Wellbeing Lab. Our webinar will be approximately 60 minutes long, and we encourage you to submit questions during and after the presentations. But please do not raise your hand. Instead, we ask that you please post your questions in the Q&A box you will see at the bottom of your window. We will hold a Q&A session after the presentation, and we will do our best to get to all of your questions during that time. A copy of the presenter's slides and a recording of this webinar will be made available on our website, which again is www.marylandrota.org. You can find the webinar page under the Services tab. Thank you, and we hope that you enjoy this webinar. Dr. Mangadu, I'll turn it over to you.
Good afternoon, everyone, and thank you very much for having us here. We are looking forward to the discussion. And like Erin said, we are also very happy that we are not having any weather-related power outages right now in our corner of the state, although the rest of the state is experiencing many snowstorm-related issues. So today we are excited to share some of our lessons learned from our border region for rural substance use disorder and opioid use disorder response. And we are going to discuss the priority communities first for our presentations, on which we are located right on the US-Mexico border, and an overview of the Minority AIDS Research Center's goals and programs. We will also present some highlights from our community academic partnership model and some of our programs which are addressing both the planning and implementation of substance use disorder and opioid use disorder in our rural minority binational communities. We will then share some lessons we have learned and some practices which we see are working for us and hopefully will be helpful for other rural communities nationwide. So about our priority communities, as you can see, this is Juarez, Mexico, and this is the United States-Mexico border, and we are located right on the border. And if you are seeing my video, my background is our campus, but if you see the gray area where the mountains are, that's Juarez, Mexico. So when I say we are on the border, we are literally on the border, and there is a place in our parking lot where we'd say it's literally a stone's throw away. We could, and I-10 is right across from us, and Juarez is on the other side of I-10. So I'm just presenting this map to show how close we are to the US Mexico border and why we cannot afford to ignore the dynamics in this region for any public health programming intervention, more so for substance use disorder, mental health, opioid use disorder programs. In addition to being on the US Mexico border, there are about 40,000 or more residents residing in areas called colonias. And this is a picture of one of our colonias on the east side of El Paso, near our rural tracks, in our rural tracks. So, for those of us not familiar with colonias, colonias are unincorporated neighborhoods where there is no infrastructure, just land is bought and people stay there and build as they go with the help of families. So you would see a home with 2 rooms, essential rooms, and then they would start building on later as when they get the resources, when there is family weekends, have a barbecue built. So there is a lot of resourcefulness in such communities, even though they are disadvantaged in other ways. So this is one of the colonias. And this is a picture from our faculty lounge. So you would say, I clicked this picture. I was standing at the glass window, and this is I-10, and this is Mexico, Juarez, Mexico. So just to put a perspective on why and how we must consider the binational context and incorporate that in all our programming. The demographics of El Paso County overall, this is El Paso County and Region 10. Our rural areas, our rural tracts in El Paso County and other 5 counties, which are all rural US Mexico border counties in Region 10. So these are our demographics. We address a total population of 880,000 plus, majority Hispanic, majority Mexican American origin or Mexican origin, many individuals speaking Spanish as the first language at home. And we have high poverty rates compared to the state and nationwide unemployment rates, and also the violent crime and sexual assault and victims of neglect. There are high numbers in these regions. So this is a characteristic of our region. In addition to this, we also in our programs use a strengths-based approach. So while it's not there on this slide, the strengths in our community are that what's called underground resourcefulness, social connectedness, and having each other's back. So that's a strength in our communities, in addition to the community partnerships we've established. So we capitalize on those as foundations for our programming while addressing these risks for SUD and OUD. So in Public Health Region 10, we have the counties of Brewster, Culberson, El Paso, Jeff Davis, Hudspeth, and Presidio. Now, out of all these counties, 5 are completely rural. El Paso has rural tracts and semi-urban, urban tracts, and they are all medically underserved areas, MUAs, and almost all are health professional shortage areas, HIPSAs, which is very important when we are trying to implement community-based direct service programs, clinical service programs for SUD and OUD, because we are already experiencing mental health professional shortage, and we are medically underserved while there are high risks for these issues. Um, we also have a highest percentage of Medicare beneficiaries, and El Paso, this border area is a high intensity drug trafficking area. So, proximity and easy access to substances, street drugs, prescription meds on both sides of the border, proximity to violence. And we had over 165,000 adults needing mental health care and substance use disorders. So, co occurring disorders is very common in the population we address. We almost never, almost always have to address both together. So that's something I want everyone to keep in mind while we're programming for substance use, opioid use, there's always a need to address the mental health and HIV and HCV prevention needs in the same person, same family, same community. Now, we implement our programs through the Minority AIDS Research Center, which I direct. And we do focus on the US Mexico border, but we have a academic community partnership model, which also has partnerships in global communities in Africa, India, and Finland. The model is same. The overall concept is that we learn from each other. We are not teaching other countries, but we are learning from other low resource settings and teaching each other. That's our foundational concept. Our mission is sustainable education and health professional education, translational and clinical research to look holistically at HIV related disparities and inequities among minority populations globally. These are our goals. One is health professional education. Almost all our projects engage students in real world contexts, community experiences, providing health education services, public health program implementation. We are interdisciplinary in terms of all the projects looking at drawing from disciplines of public health, for example, social work, anthropology, counseling. So for engineering, we try to draw upon many disciplines to provide holistic care models. We Our goal is to develop effective behavioral and technology innovations. And I can proudly say that our teams were a little ahead of it because we had established that base before the pandemic. And once the pandemic related challenges hit us, we were able to deliver most of our program services and meet our indicators compared to other similar projects because we had an infrastructure already established in terms of technology innovation. We also work with the School of Pharmacy and other pharma in next generation therapy development. Our goal is to become more of a cross cutting interdisciplinary resource for mental health, SUD, OUD, HCV, HIV, together in holistic model in both in training, infrastructure, and capacity building. So these are our goals. You can see the theme is comprehensive, holistic, community engaged, and community placed models. So, having said that, we couldn't do that without a multi-sectorial regional program partnership um, participation. Some of our main partners are these. Aliviane Inc. is the main behavioral health service provider. We have two major federally qualified healthcare centers as partners, law enforcement, the district attorney's office, the regional lead education agency, child protective services, the city of Socorro, which is one of the cities in our 6 counties, and also the regional law enforcement and clinical service providers. So, and of course, UTEP, the major Hispanic serving institutions in the region. So our partnership is um, more of a regional approach in every project we implement so that we are able to sustain outcomes beyond funding period. So these are our major partners. And this is part of my wonderful team. You see my co-presenter, Dr. Umucu, there too. This team, there are our community partners, my coordinators, who were also my health educators as students. And then you do see the peer health educators there too. This is just part of our team. We have multiple, 7 huge teams right now working together as one organization, but this is just part of my team. We also recently have a translational rural health interdisciplinary research core established in our newly established interdisciplinary research building at UTEP with a science with the lab for biomarkers, studying biomarkers to all the way to looking at, so it's bench to community model. And right now, we are having multiple projects where substance use disorder and opioid use disorder is part of this research. And I would call this more action research because we are delivering services while we conduct research. This is my team, and here I'd just like you to present the picture that how interdisciplinary and translational it is. So we do have faculty from engineering, we have basic science, neurology, and cancer research faculty. We have HIV clinical service providers. We have technology innovation faculty. We also have the Office of Border Health and Texas Department of State Health Services as partners, as team members to help us guide with the policy in it. So, and a School of Pharmacy faculty as well. So this is a very translational interdisciplinary team. I'm very excited about conducting more projects in this team from now on. So the programs we will highlight our experiences from for this webinar are the Rural Community Opioid Response Planning and Implementation Programs. Right now we are in the implementation program. Dr. Umucu will be highlighting our needs assessment findings from the planning stage. And then we will look at some highlights from Healthy Mind, that's a typo there, it's Healthy Mind and Healthy Life, which is a program which looks at mental health, a co-occurring disorder with substance use disorder and OUD. We also will look at some highlights from Mujer Saludable, Familia Feliz, Healthy Women, Happy Families. This is a program for women, and also the Pregnant Postpartum Women program, where we provide residential care for women, children, and families. So now I introduce my colleague and friend, Dr. Emre Umucu, who will be providing us with some highlights in our rural opioid response planning program. He is the evaluator for both the planning and the implementation programs. And Dr. Umucu, the stage is yours.
Thank you, Thenral. Thank you, Dr. Mangadu. Good afternoon, everyone. Great to be here and then present our, findings and, lessons, we learned from these, projects. For my part, I'm going to talk about some data and methods and then what we found from our data and assessment, plans. So we collected data to understand rural opioid use disorder needs for our region. And here I'm going to talk, our data and results. So we collected data from 121 individuals in our region, and we asked our participants many questions via surveys and questionnaires. For example, we use a demographic questionnaire to understand participants' socio-demographic characteristics. We use psychological, measures to understand their optimism, resiliency, well-being, depression, and anxiety scores. And we also, ask some questions regarding whether our participants are experiencing pain, whether they have family history of opioid use disorder, whether they have access to technology or healthcare, and whether they experience any violence. Those are some of those questions we, ask our participants. Next slide, Tana. So if you look at, our participants' characteristics, so you can see the mean age is about 46 years old from our sample. And the majority of participants were female and Hispanic, and they were also employed. And the average number of having children was 2.27 among our participants. And I think our, Hispanic population also almost matched with El Paso's, overall Hispanic population rate as well. Next slide, please. Okay, so again, now I'm going to talk more about what we found from our data, right? So first, I'm going to talk about the pain variable. So we ask our participants whether they're experiencing pain, whether they experience in the past pain or not. If you look at these statistics, so we found a total of 45 participants, which is 36% of our participants were experiencing pain in that time. And they reported, about 43% of them reported that they have used any medication for their, pain. And 20% of them were currently using pain medication for their, any pain, problem. Here, we asked our participants, whether they are seeking help or not. And I'm sure there are some clinicians here, right? So help-seeking behavior is like extremely important for us. So we wanted to understand whether our participants were, interested in or, are willing to seek help if they have been experiencing an opioid use problems for themselves or for families. So we asked them, if they have any type of, opioid use disorder. So where would they get the help? And if you look at the numbers, statistics are, really interesting. 33% said they will seek help from friends. About 56% said they will seek help from family. And about 13% said they will seek help from spiritual leader. And this is so interesting. 10% said they will seek help from psychologists, and 6.5% said they will seek help from psychiatrists. So when you look at those, mental health, care providers, actually they don't want to seek help as much as help they seek from families or friends. Even spiritual leader, they go in and seek more help if they have an opioid use disorder, problem. So this is, to me, really shocking because, we really need to increase help-seeking behavior, especially, getting help from professionals, right? So you can get advice, suggestions from families, right? But we need to, maybe do more, social, media campaigns to help these individuals to seek help from psychologists, psychiatrists or counselors or social workers. Again, another data was, only about 26% of our participants know where to seek professional help in their region regarding opioid use problem. This is also very sad to me, when you look at that, these statistics, about 80% of people do not know where to seek help if they had opioid use disorder. So we were also interested in whether they had access to healthcare. So yes, maybe you are even they have they are willing to seek help. Are they able to have access to healthcare, right? So we wanted to ask our participants whether they had difficulty to access to healthcare. So this is the good news basically. So only 16% of participants reported difficulty in accessing healthcare services. So I don't know, of course, nationwide, what is the rate for healthcare access for the United States, but I think this is not as bad as I imagined, it will be for access to healthcare. And we also ask participants, which healthcare services are the most difficult to access. So if you look at our results, 13.7% said physical health care services, and that is the highest number. And then it comes, primary care, 12.9%, and then mental health care services. So you can see, in El Paso region or in our region overall, so the most difficult healthcare service to reach is physical healthcare services, and then primary care, and then mental health care. And then it comes, preventative cares and rehabilitation healthcare services and family, domestic, and sexual violence related services. Next slide, please. Okay. So another question we were really interested in was whether our participants had access to technology, whether they are willing to use technology in their, healthcare, and whether they know how to use technology to, improve their health, physical health or mental health. So our results showed that about 78% of participants had access to technology, and about 69% of participants use any social media. And when you look at specific social media, you can see 50% use Facebook, 8.1% use Twitter, 22% use Instagram, 27% use Snapchat, and about 39% use, I think, Facebook Messenger. So these are very important. Why? Because as a clinician, if we know these populations are using Facebook more than, let's say, Twitter, we can actually create more social media campaigns in Facebook than we focus only, Twitter, if we have not enough resources. We also found that only about 18% of participants ever use online applications for their physical and mental health, such as Calm application. And this is actually very, very, again, low rate. So, and we also found only about 9% of participants reported they have been trained about how to use technology in their physical and mental health. So they don't know also how to use actual like using online applications for their physical and mental health. And there are, like now tons of applications for physical and mental health. And most importantly, 71% of them believe that technology is necessary a lot. Technology is necessary for a better healthcare system. So basically, these participants are aware technology is really, really important for better health or for healthcare, but they do not have enough training how to use it, or they're not able to use it enough. So that is another, like, I think kind of like important thing we clinicians should keep in mind. Next slide, please. Okay, so we also ask our participants, like I mentioned before, some psychological variables. So we were interested in whether they have like enough, like well-being, whether they are depressed, they have resiliency, they have like optimism, or they are anxious. So if you look at our actual like statistics and then data, we found our participants had moderate level well-being, moderate level resiliency, and moderate level optimism. And our participants also had low levels of depression and lower levels of anxiety, which is also again like kind of like good news. So they have like some kind of like resiliency and optimism, and they have like some kind of like well-being, and their depression or negative affect scores are relatively lower, which is good news. So so basically like we were really interested in like if people like if people are using some online applications for their mental and physical health, is it good for them, for their like well-being, for their depression, for their resilience and optimism? That is what we wanted to test and then see to make it evidence-based. So we compared people who use any application for their physical and mental health to people who never use any application for their physical or mental health. Basically what we found, which is so interesting, those who reported using online applications for their physical and mental health had significantly higher resilience score and significantly higher optimism scores compared to those who never use online applications for their mental health and physical health. So that means actually online applications are helping, online applications for physical health and mental health help these individuals to have better resilience scores and optimism scores. Next slide, please. This is another interesting finding. So we did same analysis for well-being, depression, and anxiety scores. And this is so interesting because so those people who use online applications for physical health and mental health did not have significantly higher well-being scores or did not have significantly lower depression or anxiety scores compared to those who never use online applications for their physical health and mental health. So what that means, so these findings indicate that those who use applications for their physical and mental health do not have significant differences for well-being, depression, and anxiety, but they have significant differences for resiliency and optimism. So next slide, please. Thank you. So what lessons we learned from this data for like opioid use disorder need assessment? Because we are also going to do like implementation, right, for this year and the next 3 years. So it is very important for us. We use these statistics and data to capture bigger picture for our like population and for our region. So number one to us is like pain is common among our participants and in our region. So that I think healthcare professionals should be screening and monitoring pain more like commonly in participants in like region. Again, sadly, only about 26% of participants know where to seek professional help in their region regarding opioid use problem. To me, this is very, very, like, this makes me like really think deeply, like only 26% know where to seek help. This is like very sad news for our region. So in implementation page, like phase, maybe we will do more campaigns, right? So to help these people and make some campaigns to let them know where to seek help for opioid use disorder. So given technology use and social media use are very common among participants nowadays, so programs can develop social media campaigns regarding opioid use disorder and it is interventions. That is very important, like for, I think, opioid use disorder, population. And another lessons we learned, online mental health and physical health applications could be helpful for individuals to be more resilient and optimism. And just, resilience and optimism are very, very protective factors regarding some psychopathological traits like depression, anxiety, stress. So if you are resilient, you can cope better with pain. So that's why we want these people to be more resilient. So then they don't need to apply other like negative coping strategies such as opioid use disorder. So it's also important to consider like improving resilience and optimism in populations. Lastly, community healthcare providers should do more psychoeducation and trainings regarding opioid use disorders and inform society regarding opioid use disorder and available resources. As you know, our data shows very clear that these individuals do not know where to seek help. They do not know how to use applications. They do not know whether there are available services for like them if they had opioid use disorder. So our job is basically to increase these like awareness for resources in community, especially in this region because there are so less and like limited resources. We just need to make sure we teach and train these people. These are the resources available for you whenever you need to seek help. So that is all I have for my part. Thank you, Dr. Mangadu.
Thank you, Dr. Umuku. And as Dr. Umuku said, the sort of the dilemma now is that people don't know where to seek help, but we have the health professional shortage, and we do have they so both the risks are high, health professional shortages there, and then they don't know where to seek help. So we need to address all these issues simultaneously. And so now this is our assessment. We are in the implementation of that particular program. We are incorporating what we learned during assessment in all the program activities. Now I'd like to share some highlights from the programs we have been implementing over the past 5 years to address SUD and OUD in relation to multiple disparities in adults 18 years and older, and also women and pregnant postpartum women. So our first program is Healthy Mind, Healthy Life. And here we do serve women and men who have a co-occurring disorder, um, which is substance use disorder, serious mental illness. But what we do here is integrate this care in primary care settings along with HIV prevention, since these all coexist most of the time. In the next program, the Purmi Familia is for pregnant and postpartum women. Again, the holistic modeling I had mentioned before, the concept here is to serve women, families, children together, bring in the fathers or the father figures. And I'd like to emphasize that because in our region, in this population, and it might be similar in other regions, when we had to engage fathers of the children in care and families, strengthening families, what we observed was most of the fathers were also using, and they may have been in a residential, or they were incarcerated. So we had to get of the father figures. It could be a grandparent, an uncle, also engaged in programming. So in Purmi Familia, we provide residential care for substance use disorder, opioid use disorder. It is trauma informed, but we also emphasize spiritual health, mindfulness, coping, and nutrition, food insecurity, basic needs, and recovery support as part of the programming. The next program is Mujer Saludable Familia Feliz, which means healthy women, happy families. So again, trauma-informed holistic care. We had a healthy model food pantry established. We paid attention to what was really the problem, what was the foundational risks for opioid use disorder and substance use disorder. And so this program focuses on addressing healthy relationships, food insecurity, SUD and OUD treatment, and mental health. So these are the three programs, and I'm going to present some highlights, better practices, and lessons learned from our community. Like I said, the focus was integrating SUD and OUD care with HIV, HCV, serious mental illness, co-occurring disorders, prevention, treatment, and recovery support, which we have found overall this foundational approach to be very effective in participant recruitment and retention, because very often the same individual um, experiences all of these disparities, and they intersect with each other. They feed into each other to increase the risk for SUD and OUD. So this is our community engagement activities in the good old days when we could see people in person. Right now we have more virtual engagement, mobile units, social distanced activities. This is our Zen garden, we call it. This is a little in the pregnant postpartum women residential facility. So they're still gardening. And this is what we've been able to do, engage traditional, non-traditional sites, community stakeholders in programming. So as overall, the services we provide begin with screening in the community by trained case managers, screening personnel. We do have program assistants who are our health education students trained in screening, and we do have certified testers. So that's done almost always in the community settings, multiple types of community setting. It could be clinics, it could be grocery store parking lots. Again, this was pre-COVID pandemic, and I'll talk a little bit about how we have to adjust all that to accommodate for the pandemic-related challenges and barriers. Following that, we had screenings, referrals, linkages for mental illness, SUD, OUD, co-occurring disorder, and trauma. We do partner with our Center Against Sexual and Family Violence. So very often there is a need for intra-agency referrals. And so we have a tracking system to see who's going and getting services from all of our partners. The interventions are mental health, again, violence prevention, victim assistance, SUD, OUD care, excuse me, mind-body bridging, family strengthening, and nutrition. So the point emphasized here is that when we address SUD and OUD, we always address the co-occurring risks and what the consumers or the clients overall needs, which will help them cope better and uh, and be in recovery. So for the healthy life, healthy mind, I'm just going to present some of the impacts we've had so far. We've provided about 368 HCV tests as of now, and intensive case management, now 114 intensive case management over the third year now. It is a lot for our community given the health professional and mental health professional shortage. We do a lot of outreach for stigma reduction, a very, very vital component in our rural regions. As Dr. Umuku presented, they don't know where to seek help, but a very few say they will seek help with mental health professionals or providers for substance use disorder. There's a huge level of stigma for mental illness and substance use disorder, even seeking support for domestic violence, intimate partner violence. So we incorporate that in our outreach. For the pregnant postpartum women, Pour Mi Familia or For My Family program, we have so far 78 women with children below 13 years staying in our residential facility. It's a 50-bed facility. We have our licensed counselors, LPCs, therapists, and other providers, case managers in-house. We also have a healthy model food pantry established there. So we do take care of their mental and physical health, or also the healing food, so-called mindfulness, right, through nutrition. And we provide family strengthening um, services and activities for residential participants, but also for their families who are non-residential. For the Mujer Soledad program, we have been able to conduct over 1,500 HIV tests, 1,300 Hep C tests, and 1,500 screenings in the community and connect them through the programs. And what worked for us is these programs working together in terms of referral. So if somebody does not qualify to receive services. Let's say a woman who needs care for SUD and OUD does not qualify for the Pregnant Postpartum Women program, because in that program, the woman should be pregnant or have a child under 12 months of age. So if they do not qualify, we will be able to refer that participant to another program, either the Mujer Solidab, or if there is a co-occurring disorder, to receiving services from Healthy Mind, Healthy Life. So we were working together, leveraging resources. Now, some participant feedback from these programs. Right now, we have one program, we have 88% retention rate. And in our pregnant postpartum women, we have one of the best retention rates among national grantees, other fellow grantees, according to our program officer, because despite the COVID pandemic, and and we have been creative and proactive in the strategies we've employed to have that retention rate. Now, in this participant feedback, we chose these quotes to show why a holistic approach works best for us, particularly in rural and underserved communities. So we do need to provide, so this participant says they have received many types of services. So it's not only direct HIV testing, direct SUD care, but support services for themselves and their children. And acknowledging or helping and addressing mental illness was key. And going through the cognitive behavioral therapy greatly helped this participant in coping. So these two quotes show that a variety of services are needed, and we do need to understand and address the mental health aspect in SUD and OUD care. Now, in these three quotes, we chose these because it highlights how family involvement, bystander involvement, community engagement, particularly engaging the significant others, is very important. So the first quote is from our participant who says, um, the communication has improved because of our program with their families, her mother, the children, and a better understanding of herself. We also have a mind body bridging. So, this participant there, we engage moms with their children in activities. So, this participant expresses how that activity was important and helpful in addition to the treatment, the other treatment, the clinical services she's been receiving. Now, the last quote is about parenting. I know many of us may have this experience. Something very normal for children, outside a residential facility, other children in the community who do not have a parent with a substance use disorder. Um, it's an amazing opportunity for children or experience for just to decorate a Christmas tree with their mom in residential facility, to do some drawing activities, to do gardening, to have dinner with their mom. And we've seen that, and we have this parenting and mind body bridging classes in the residential facility, which helps families, moms, connect with their children, spend time. And that in turn, we observe and we hope will foster better coping and better recovery support. Now, in this slide, the focus is about other recovery support services. Our programs, given our transportation barriers and barriers to primary care access, barriers to, right now it's with technology, the internet, the Wi-Fi hotspots, we provide referrals, linkages to all of those services through our programs. And that has been one of the main strategies to help retain our clients even during follow-up. So you could see that we provide referrals and products from our food pantries. So we assemble kits, healthy food kits, where in our donations, we actually request healthy alternatives, low sodium products, for example, olive oil instead of other oils. and low sodium spices and herbs. And we have a recipe booklet. So we do pass on these kits with recipe booklets and then fresh food items and ingredients for them to help make that. And we do have a promising practice intervention delivered where we do teach easy food prep with ingredients we can find in the corner stores because we are food deserts. So if they need to sustain in recovery after residential treatment or during treatment or after the program, we believe that we need to build that support system for them to integrate into the community. So that's what we do. And these quotes refer to those other services we provide, whether be it transportation to treatment. Project Vida is our federally qualified health center partner. So the food pantries and even education. So I have been in communication with our um, with the with UTEP where we are exploring how we can talk about access to higher education aspirations. So these are some of the things which have been effective for us. Now, planning the SUD programs in our rural communities, what are some of the things to consider? What we do have to consider every time is the one is the distance to program sites. We are over 25,000 square miles, about 25,000 square miles in the rural counties. And then in addition, El Paso rural tracts. So we need to plan how we would cover those miles, who would be at the site, and how would the program team manage this through all program services delivered. Next is the buy-in, right? Why should they trust us? These are communities historically disadvantaged. Being in the border, they have a fear of authority. The immigration issues. Anybody is seen as the immigration authority. So why would the community members trust us? Why should they trust us, work with us? And they have been many times they have been the source for data for academic research but not for service delivery. So we need to consider all that, and our community partnership model has specific bylaws for community and academic partners expectations. That way we have the buy-in of the community partners to say you are going to be doing service and action research. Our needs are going to be addressed immediately, not just you getting publications. So things like that. So it's very important to have that model. We also have to plan what would be the roles for local first responders and health professionals. As we all know, in these communities, they wear multiple hats. So what it's very important we have to be clear on what their roles would be in our programs. Community members' roles. Are we going to have community health workers trained? We call them promotoras here. So what would be their role if they have a role in the program? Would community members help in outreach, in recruitment, retention, evaluation? So planning that helps for rural community program implementation. Data collection, the sensitivity and relevancy. This is something which we emphasize in our program because we want to make sure, again, talk about the continued trust and sustainability. We do want to make sure that we are collecting data which is meaningful for this community, regionally relevant, culturally sensitive. So something to think about as we are developing our instruments. And yes, we do want our analysis, we do want our results, but are those variables important for the community? And that's where we have a community driven approach. We have our expertise in research, in evaluation, but the community partners guide us on the variables to be examined. Reporting and analysis, again, we always plan for multiple audiences, customizing our reports, town halls, letting the community know what happened from this program, what are we doing, and is there going to be another project? So these are some of the things, and of course, services delivered and research. Last but not the least, we have been very adamant that every project we have will have the service component. There can be an assessment component. Yes, there could be research involved, However, there should be services delivered because of the immediate needs in our community. So when planning OUD and SUD programs, these are the contexts which have been useful for us to consider. Um, Again, the incentives. When we talk about incentives, there can be tangible incentives, but also an incentive could be referral and connection to support services. Things like getting a GED, victim assistance, Wi-Fi hotspots. So think creative, thinking creatively in terms of our incentives has also helped us. Overall, we have to plan for sustainability. Given the funding scenario, given the rural context, the health professional shortage context, we have to start planning for sustainability right from year one. And I have to say, looking back 6 years, that buy-in and trust we had at the community level with the multiple partnerships. Now, all those partnerships have been established over 9 or 10 years, step by step. That has helped us with sustainability because next, when there is a funding opportunity, when there is a program development, partners pitch in. We do not have to start from scratch. So those are in general. And we know what happened the past year. We had to navigate COVID pandemic, 19 pandemic related challenges too. So we had challenges in relation to social distancing guidelines and service implementation. We had to move to telehealth, to outreach in virtual settings, in social distance with social distancing guidelines in person. Data collection, again, had to be, all our IRB protocols had to be modified. So that's something we did. If something could wait, we have postponed some focus groups. Given our the population we deal with, we have to have extra emphasis on anonymity, confidentiality in the virtual world. So that's something to consider, what we had to modify. While this was happening, increased risk for SUD and OUD and mental illness because of pandemic related stress. So, how do we deal with the challenges in offering services and the increased risk, the need, the demand for our services? That's where our teams had to get creative. And I wouldn't say there is a one size fits all answer there, but our community partners integrating services in multiple sites has certainly helped, and utilizing community health workers has helped. Now, technology, infrastructure, navigation, as I mentioned before, we were a step ahead over there because we had some apps developed, we had social media, social network sites set up, and telehealth set up. So we were in a better place, but I would certainly recommend that from moving forward, we have this as a component of every project we implement. Another thing to consider is the COVID-19 testing and vaccination access for all our clients, because they would need that too. And again, rural areas right now with the vaccine rollout and testing, we should be sensitive, and we try to incorporate that when we do our outreach and program services for OUD and SUD. So that is another thing which shows the community you care about holistic health. It's again about that caring as a person that helps clients want to retain in our programs and recovery. So the lessons learned, we had this community academic partnership, which is mutually beneficial and transformative, is helpful. And we do have our model and bylaws. We have trained over 400 health professionals. We'll be happy to share it with anyone who wants to contact me. Please send me an email. That's something we could do. It's worked for us to build a systems level change or infrastructure. Coordination among local programs. If you have multiple programs addressing SUD, OUD as a component, but in related health disparities, coordinating together and leveraging the resources has helped. Like I said, for referrals, if you don't qualify for, if a person does not qualify for one program, they may qualify for another program. That way, they're not sent back without services. And while both the programs may be then be able to get their indicators, right? We do need the indicators for reporting and funding extension too. Always addressing the support and essential services, food insecurity, education, employment needs, housing, transportation. We do give transportation gift cards. So those addressing those help. We have now, since of social distancing, our family navigators. We do have them employed, and they do deliver the food bags and whatever they need for children who are non-residential. So for an individual to be effective in coping and adhere to treatment, we have seen that the peace of mind that their family is taken care of or the basic needs are addressed is important. And we do have all our program services when in person, when we are in person in many sites, primary care settings, traditional, sites like clinics, but also non-traditional sites, farmers markets, our grocery store parking lots, our church parking lots. So we have many non-traditional sites. School districts help us with their sites also. And technology has also helped us, like I mentioned before. We had to have flexible budget planning, especially with the COVID pandemic, but even in general, from year one to year two, to we need to be flexible in seeing how our budgets are spent. Last but not the least, timely and continuous communication with your program officer. Be an advocate for your community. That's what worked for us. In one of our programs, there were many barriers because there were some incidents in our community, trauma, community wide trauma, which prevented us with our recruitment indicators. But we were able to document that as part of program evaluation. I cannot emphasize enough how important process evaluation is in documenting. But with that documentation, we were able to communicate in a timely and continuous manner with our program officer, thereby advocating, and we could advocate for a change of scope in our program and then get the deliverables done. Also, technical assistant requests. SAMHSA has an amazing variety of technical assistance resources for opioid use disorder. And we are presenting one such resources is our organization here. So please request. This has been very helpful for us. Always, we requested technical assistance related to multiple program components, social marketing also being one of them. So I would highly recommend. These are some lessons which work for us, but this I this may be the one of the better practices to explore in other rural areas. So I call them better practices, not best practices, because they evolve. So hence they are better at this point, better practices. Um, Plan a multi-sectorial partnership showing up in the regions. These are faraway rural regions. If we have to be there, for me, it's a one-way drive, a 4-hour drive one way to one of our rural counties. But we have to be there in the ground to make those relationships and connections, to show we care. Self-care, I put this on the top of the list because we do need it in this environment with the issues we are addressing in substance use disorder, opioid use, the COVID-19 pandemic. Excuse me, we need to look at self-care for our program teams and service provider. Our program meetings are always start with how are you doing? How is your family? And then we go on to our other agenda items. Thinking big picture. So we have sustainability. I would say we have strengthened our sustainability and replicability of programs because of the type of partnership structure we have established. So projects come and go, partnerships sustain. Something to explore in every region, and for us, it's been effective. Incorporating related disparities in all the evidence-based interventions helps. It's not only substance use, opioid use, it's almost always mental health, intimate partner violence, food insecurity. Um, it's worthwhile to think about it. Addressing support services, immediate basic needs of individuals, and very important, documenting and continuing promising practices. And always engage your future professionals. We have our students always engaged. So there is caring and community context, relatable community context engagement right from their training. Technology again. So these are our better practices and which work for us, some lessons learned. I would say these are references. This is our acknowledgement. These are the 3 SAMHSA grants, and we also want to acknowledge the HRSA Rural Opioid Response Implementation and Planning grants. For further queries, please email us. This is our email, and this would be the Minority ARC website. So please do not hesitate to contact us for any further queries. Thank you very much.
Thank you so much for that great presentation, Dr. Mangadu and Dr. Umucu. I really appreciate all the information you shared. That was a wealth of advice and suggestions for our participants, and I'm sure it's engendered a lot of thought and discussion among them. So I want to encourage all of you out there to please submit your questions in the Q&A box, because we're going to switch over to our Q&A session now. So I will start with a question from a participant who would like to know, how do you deal with uninsured population with substance opioid use disorders?
We do not having insurance. No, not having insurance is not an exclusion criteria. We do work with our service providers, the behavioral health, the federally qualified health centers. So they do have their own system where they have third-party providers who can help with it. They have state funding. So we leverage funding from multiple resources, not only through MARC, but the direct service providers. And that's how we've been able to address that issue.
All right, thank you for that. If there are any other questions, again, submit to us, please, the Q&A box. And also, I encourage you to go visit the Maryland Rhoda website at marylandrhoda.org, and you'll see information about many other educational and training opportunities that are provided through Maryland Rhoda, and information about local drug trends in Maryland and so on. And I also encourage you to join us for our next webinar, which is coming up in April, on April the 8th at 2 p.m., when we will be joined by a panel of experts from the Mid-Atlantic Telehealth Resource Center, and also a couple regional practitioners from Western Maryland who are going to be talking about their on-the-ground experience in implementing telehealth before and during the COVID pandemic. So I hope you'll be available to join us then, and keep an eye out for our announcement in the future about that, and also our other webinars as they come up in the coming months. Here is one last question. So I will share that with you. And that is, what do you recommend as strategies to reach out with populations that have limited access to internet or to telehealth services?
We have been exploring that. One thing which has worked is having, one is the access to the internet itself, and then it's the navigation, 2 issues we face. So having the primary care settings and family navigators and social workers there when they come for services, right, or counseling, OT, PT. So having those settings work with us in service delivery has helped. In terms of technology navigation, we also have promotoras who may have to help individuals, especially our senior population, right, to navigate the technology. So those are the 2 issues we've faced, and right now that's working. We in fact have some of our partners leverage their funding to purchase Wi-Fi hotspots for some populations. So again, I cannot emphasize that partnership model. Just by ourselves, the Minority AIDS Research Center would not be able to do this. But if you have a federally qualified health center, a behavioral health service provider, a school district, a primary care setting work together, then it's been very helpful for us.
All right, well, thank you so much. And thank you everyone for joining us for the webinar this afternoon. And we hope we see you again for our next Maryland Rhoda webinar in April. Have a good day.
You too. Thank you all.